Hey friends, welcome back. Today we'll be discussing questions from Neet 2018, the Obs and Gynae questions. The first question that I want to discuss is this important one. Sacrocolpopexy is done for prolapse of which compartment? Now, to be able to answer this question, you should first understand what are the compartments of pelvic organ prolapse. How is pelvic organ prolapse classified into various compartments? Now, if you see this diagram, this diagrammatic representation of the pelvis, the anterior part is the bladder and the urethra. So, a prolapse of these two structures through the vagina is called anterior compartment prolapse. Second is the middle compartment, which comprises of the uterus, the cervix, and the vagina. If these things descend downwards towards or through the vagina, it's called middle compartment or apical prolapse, or uterovaginal or a uterocervical prolapse. Third is the posterior compartment. Posterior compartment is it includes in the pouch of Douglas, prolapse through the pouch of Douglas. Pouch of Douglas is reflections of visceral peritoneum from the posterior uterine wall and from the anterior wall of rectum, or rather the posterior abdominal wall. Now, gut loops, small bowel loops can prolapse through this and descend downwards, pushing the posterior vaginal wall. That's called an enterocele. Similarly, the rectum may prolapse through the posterior vaginal wall, descend downwards. This is called rectocele. Now that's how you classify prolapse into different compartments. The anterior compartment, the lower part will be called urethrocoele and the upper part urethrocoele. The upper part can be divided into further 4 grades. First grade will be, now remember 1, 2, 3 grades are with straining. First grade is bulge inside vagina above the introitus with straining. Second is up to the introitus with straining. Third is beyond introitus with straining. And fourth is beyond introitus outside the vulva at all times without straining. Right, then the middle compartment will again be graded into 1, 2, 3 based on how distant it is from the introitus. 4 will be complete prolapse of fundus, complete prolapse of the uterus including the fundus outside the vagina beyond the introitus. Then posterior compartment can be classified variously. One way will be to classify the upper 1/3 as enterocele. Upper 1/3 of posterior vaginal wall, if it prolapses, it usually brings small bowel loops through it. So it's called enterocele. Rectocele will be the middle 1/3 and the lower 1/3. The lower 1/3 can also be called lax perineum. Now coming to the management of prolapse. Prolapse management can be divided into non-surgical management and surgical management. Now remember, the definitive management of prolapse is going to be surgical. Non-surgical management has certain indications. When there are limitations to surgery, when you cannot do a surgery or the patient is refusing a surgery, we resort to non-surgical methods. And one more important thing is that it is used only for mild to moderate prolapses. So, if there's a patient who desires to preserve her fertility and she has a mild grade of prolapse, you can opt for a non-surgical management. And there are women who have comorbidities, like they have medical conditions which because of which there are high risk for surgery, such major surgeries. So we prefer non-surgical managements in them. You have to explain to the patient that these non-surgical managements will prevent worsening of prolapse, will decrease the severity of symptoms. They might decrease the severity of symptoms like the urinary symptoms and the bowel symptoms that they have because of prolapse. If done properly, these methods might increase the strength of pelvic floor muscles and they will avoid or delay surgical intervention. So basically the point is, if there's a second degree prolapse, you opt for non-surgical managements, it might delay its progression to third degree prolapse, but it will not cause the regression of a second degree prolapse to first degree prolapse. So it doesn't decrease your grade or your degree of prolapse, it only delays its progression. All right. So the various surgical methods non-surgical methods that can be used are, first three are lifestyle modifications to decrease the predisposing factors. Like we all know that obesity, diabetes, smoking, all these predispose to prolapse or increase severity of prolapse. So you will advise them to reduce weight, control sugars and cessation of smoking. Apart from that, Kegel's exercise, tightening of pelvic floor muscles may be explained to the patients. Ring pessaries, these are ring shaped pessaries which are kept up in vagina to keep the pelvic organ suspended. Splinting of rectocele in the vagina. When there's a rectocele from the posterior wall, what you do is you ask the patient to keep 2 fingers in the vagina while passing stool. So what it does is prevents progression of rectal prolapse because of straining. Then coming to the surgical management. Surgical managements broadly will be classified compartment wise. Which surgeries will be done for anterior compartment prolapse? There will be different surgeries for posterior compartment and for apical compartment repairs. Sometimes you have prolapse of all the compartments and then you have to do a mix of all these procedures is done. The procedures that I'm going to explain now. Compartment wise, for each compartment you have a native tissue repair and you have a mesh plasty that can be done. Now, if you talk of apical prolapse, that is uterovaginal or uterocervical prolapse, the native tissue repairs that can be done are macular scaldoplasty, iliococcygeus fixation, sacrospinous ligament fixation, uterosacral ligament fixation. Now, all these things are just names. You're not expected to know what is done in them. All you need to know is that these procedures are done for apical prolapses and these are native tissue repairs. There's no mesh used here. Then there's mesh plasty, or the mesh plasty which is done for apical prolapse is called sacrocolpopexy. It's an abdominal procedure. Now remember, the mesh that we place for apical prolapses is placed abdominally. You can do it open by laparoscopy or by robotics techniques. Now, one more important thing is that mesh plasty these days is considered the gold standard surgical procedure for apical prolapses. Now, what is the sacrocolpopexy? Sacrum. Now, that's your sacrum. I am very poor at drawing diagrams, and especially when you have to draw diagrams with a pen on a computer. It's difficult. So, that's diagrammatic sacrum of this female, and that's a diagrammatic vagina. Yeah, that's the uterus. Right, this I am trying to show the sagittal plane when there's vagina and there's the sacrum. Actually, the vagina should have prolapse. So what we do in this sacrocolpopexy is we suture one part of the mesh here and the other part, the sacrum, should be high because the organ has prolapsed. Yes. Now see this. This is the prolapsed vagina. What I do is I stitch one end of a broad part of a mesh is stitched here. The other end of the mesh is stitched to the longitudinal ligaments over the sacrum at the promontory. That is sacrocolpopexy. It is done abdominally and it is the gold standard surgical procedure for apical prolapses. Did you get this? Now coming to the anterior compartment. In the anterior compartment, what you simply do is a vaginal procedure called anterior colporrhaphy. It's a native tissue repair for anterior compartment prolapse. And the mesh plasty that you can do here is transvaginal mesh repair. Now this is not abdominal. Here a mesh is placed at the interface between the bladder and the anterior vaginal wall. You place a mesh here to strengthen this tissue and to prevent further prolapse. To correct the prolapse rather. Now this studies have shown that it is associated with improved anatomic support but does not result in significant improvement in quality of life parameters. So basically mesh and anterior colporrhaphy, this native tissue repair for anterior compartment prolapse will have the same quality of life improvements. So actually this is not very recommended. Transvaginal mesh plasty is not recommended for anterior compartment prolapse. You may do it, but why do an additional procedure when native tissue repair also has the same outcomes? For posterior compartment prolapse, we do posterior colporrhaphy and transvaginal mesh repair. Evidence does not support the use of any grafts at the time of posterior vaginal repair. So transvaginally, a mesh should not be placed between the rectum and the vagina because this has been associated with mesh exposures. Sexually active women had higher chances of mesh exposure and that's a tongue twister, mesh exposure and infections. Right, so transvaginal mesh plasty both for anterior and posterior compartment prolapses are basically not very recommended, while transabdominal mesh plasty, which is done for apical prolapses, is the gold standard repair for apical prolapse. Understood. Now, one more important thing is most of the times the prolapses of all the compartments, and generally for anterior compartment prolapse, you always prefer to do an anterior colporrhaphy with an apical repair. It could be a native tissue apical repair or an abdominal Meshplasty. Right. So the answer to your question, sacrocolpopexy is done for prolapse of apical compartments. Right. Now coming to the next, another important question, mechanism of action of progesterone only pills. Now, there are various hormonal contraceptives that are available. You have OC pills, you have progesterone only pills, and then you have the long acting hormonal contraceptives. You also have progesterone intrauterine device. So let's classify them. Let's understand what is the mechanism of action of each of these hormonal contraceptives. The basic mechanisms are similar. The difference is in the combination of these mechanisms which each drug is resulting in. Like you can broadly classify hormonal contraception into short acting and long acting. Short acting would be combined OC pills, progesterone only pills, and the long acting ones would be injectables, implants, and progesterone IUD. Now the basic mechanism of these hormonal contraceptions is three things. One is inhibition of ovulation, right? Second is thick cervical mucus, and the third is endometrial atrophy. All of these hormones will have one or more of these mechanisms of actions, right? And additionally, for intrauterine device, you also have the foreign body reaction. So now this basically depends on the dose of each component hormone. The hormonal contraceptives basically have estrogen and progesterone in them. Based on how much estrogen and how much progesterone is there, they will have either the action of inhibition of ovulation or making the cervical mucus thick or causing endometrial atrophy or decidualization. This all depends on what dose of each component hormone is there. Now, to give you a rough idea, this is a table that I've made. Combined OC pills will have 20 to 50 micrograms of ethinyl estradiol and levonorgestrel in the range of 100 to 250 micrograms. Right. When you come to mini pill, it doesn't have estrogen, and the progesterone dose that it has is almost half to one third of combined ossiples. So mini pill not only does not have estrogen, it also has a very low dose of progesterone. Next is progesterone injectables. These are high dose progesterones. This is Dumpa or dipot medroxyprogesterone acetate, 150 mg, and it is given at 3 months. A repeat dose is given at 3 months. Now consider, this is a very theoretic division that I'm telling you. Consider 150 mg I give for 3 months. So for 1 month, considering that an equal amount of drug and the entire drug is released into the body in 3 months, considering this, you can say that in 1 month, the drug that is available for use is around 50 mg. So for 1 day, this is 1 month or 30 days. So for 1 day, you will have 50 mg by 30 mg. That is close to 1.2 milligrams. Now this is the amount of theoretic amount of DMPA which should be available in blood every day once Dampa is injected to a person. Now see, this dose is in milligrams, and when we were seeing combined ossipils and minipils, the doses were in micrograms. So progesterone injectables are high dose progesterones, right? That's the difference between the dosages. That is what decides the mechanism of action of all these drugs. Combined injectables, they have dosage similar to COCs, combined ossipils, 5 mg ethinyl valerate and net N 25 mg. They have an action similar to oral contraceptives. Progesterone IUD, 52 mg in the intrauterine device, which elutes 20 micrograms daily. Now this is similar to a POP dose, progesterone only pill dose. So the mechanism of action of this and the mini pill and progesterone IUD should be similar. Now coming to progesterone only implants, another method of long acting reversible contraception. Here you have three kinds of implants: Norplan, Zedel, and Implanon. Norplan and Zedel have levonorgestrel, while Implanon has 3-ketodesogestrel, which is also called etonorgestrel. The doses are 216 mg, 150 mg, and 68 mg. Now, these are used for years, 5 years, 5 years, and Implanon for 3 years. The amount of drug available, now this is not theoretic, this is given in the books, this is correct. First month they will release, these implants will release around 85 microgram or 100 microgram of levonorgestrel per day. 2 years later, after 2 years, the level stabilized to 30 microgram per day. Now 30 microgram, if you remember, is a dose similar to the dose of progesterone only pills or mini pills. So basically what I want you to remember is that the mechanism of action of progesterone only pills, progesterone IUD, and implants are going to be somewhat similar, and the mechanism of action of combined OC pills, combined injectables, okay, I'm drawing the same sign for all, combined OC pills and combined injectables is going to be similar. Progesterone injectables, because of their high dose of progesterone, have a little different action. Now let's see the mechanism of actions of all of these drugs. God, this app is really slow. Yeah, the mechanisms. Combined OC pills or combined injectable contraceptives, they inhibit ovulation. Now, the mechanism here of inhibition of ovulation is when you give a combined OC pill, it has estrogen plus progesterone. If you have seen one of my menstrual cycle YouTube videos, you will understand how giving estrogen and progesterone to a patient will decrease the amount of FSH and LH secreted in her body. Now, if FSH, LH have decreased, it finally results in an ovulation, because all you require for ovulation is follicle stimulating hormone for growth of the follicles, formation of the mature antral follicle, and then LH to trigger an ovulation. So giving E plus P in the form of combined OC pills decreases FSH and LH in the body, decreases FSH LH secretion from the hypothalamus and pituitary, and then finally results in an ovulation. So there is inhibition of ovulation. Then endometrial atrophy and thick cervical mucus. These two actions are actions of progesterone component of contraceptive. Since it has progesterone, progesterone has endometrial decidolizing or atrophic effect on the endometrium, whereas estrogen causes proliferation of endometrium, progesterone causes endometrial atrophy. Now when we give E plus P in combined OC pills, the dose of estrogen is very low. It is much lower than the physiologic levels of estrogen in the body. This amount of estrogen is only helpful in this negative feedback effects. It does not have any major effects on the female genital tract. That is, it is not going to have an effect on the endometrium. It is not going to have an effect on the cervical mucus. That's why at the level of endometrium and at the level of cervical mucus, progesterone is the hormone that is primarily acting. Right, so because of estrogen as well as progesterone, you have this action of inhibition of ovulation through decrease of FSH and LH, and because of the progesterone, you have the effect of endometrial atrophy and thickening of cervical mucus. This thick cervical mucus makes the female genital tract impermeable to ascending spermatocytes because of presence of excessive progesterones. Now coming to progesterone only pills, which are very low dose progesterones given daily. They do not inhibit ovulation because the progesterone dose in them is very low. It is only able to have an action on the endometrium and cervical mucus. Then coming to progesterone implants. Now if you remember the table, I said for the first 2 years, when you place the implant in the person's body, for the first month the amount of drug released is 85 microgram, 100 microgram, a comparatively higher dose of progesterone is released. So there is erratic inhibition of ovulation for the first few years. Okay, sorry, we are not discussing this. We're actually discussing implants. So for the first 2 years of use, you can have inconsistent inhibition of ovulation with progesterone implants as well. Whereas the main actions which will be persistent throughout their use are these two: endometrial atrophy and thick cervical mucus. All right. Now coming to progesterone injectables, which if you remember I had already told you, they are high dose progesterones. At such high doses, progesterone is able to inhibit gonadotropin secretion, and it is able to cause an ovulation as well. So there is one progesterone only contraception which is able to inhibit ovulation throughout its usage. It is progesterone injectables, or depot medroxyprogesterone acetate. All right, definitely the action of endometrial atrophy and thickening of cervical mucus is there with progesterone injectables as well. Then Progestasert, which was used earlier, or Mirena, which is levonorgestrel intrauterine system. It can inhibit ovulation in some women, very inconsistent. You cannot depend on the anovulatory effect on Mirena. Basically, the action is endometrial atrophy and weak foreign body reaction at the level of uterus and the endometrium. And it also makes cervical mucus thick because of its local action. So, your answer for this question, slow up. Yeah, so your answer for this question is it does not suppress. Okay. It does not suppress ovulation. Completely, definitely not. It does not suppress ovulation sometimes. See, if you're using a contraceptive, even if it does suppress ovulation sometimes, you cannot depend on this action. So this action should not be correct for any mechanism of action. If it suppresses ovulation sometimes, it is going to have a high failure rate. Whatever, but progesterone only pills definitely do not suppress ovulation. Now, thick cervical mucus definitely is the answer after the discussion. But how about this option, luteal phase changes? Now, luteal phase changes, you will think that progesterone only pills causes endometrial atrophy. It does cause luteinization, or rather it does cause changes associated with luteal phase. But luteal phase is the phase which occurs after ovulation, right? This refers to the phase in ovary, the phase of hormone secretion. And progesterone only pill is not affecting your ovary at all. It is not affecting the HPO axis, so it does not actually bring about luteal phase changes. What it does is end organ effect on the uterus and the cervix. So the mechanism of action of progesterone only pills in this answer is only going to be thickening of cervical mucus. All right, that's the end of this video. I'll be discussing the rest of the questions in the next videos. After your responses, if you like it, share it. I'll post the other questions as well. Thank you very much.